My name is Chet Donnelly. I'm a spine surgeon here in Dallas, Texas. Sometimes on the weekends I jump onto these and do some live streams, just kind of go over a couple questions that patients might have about spine surgery, different topics in the spine community. So I'll just kind of take questions as we go. I'll answer a couple questions and then kind of go over different topics. Some of the main topics I talk about, and one of the favorite topics I have, is spinal stenosis. So if you have questions about spinal stenosis, if you've heard about spinal stenosis, go ahead and ask. I'll first start with some definitions. So the first question I get asked is, well, what is spinal stenosis? Let's break down what that word is. First, spine. So you have the lumbar spine, thoracic spine, and then cervical spine above that. In terms of the lumbar spine, if you look down the tunnel, this is the thecal sac, and it's what all of the nerves run down. So you can use this model also. This is the thecal sac, and all the nerves are running down here. So when you have something called spinal stenosis, that's when the nerves all get squeezed. It's one of the most common conditions that we have in spine surgery, that we have in spine care. Again, my background is I'm a spine surgeon here in Dallas, Texas. I was born and raised in Dallas, Texas. And then I spent the next 11 years kind of training all over America. In terms of definitions, it goes bone, disc, bone, bone, disc, bone. You have these little nerves right here called the foramen. And these foramen are where the nerves come out. When the nerves get pinched, that's what causes the sensation of sciatica. That's what causes the numbness and tingling going down the leg, numbness and tingling to the arm, shoulder, or even weakness. Raj, one of my longtime followers, I see you asking some questions on our YouTube platform, and I appreciate it. Raj is always asking me, which I always appreciate, about his C1 and Atlas being misaligned. Well, let's kind of talk about what that is, and I'll kind of get into some other questions. So, if this is the cervical spine, thoracic spine, lumbar spine, you have the atlas and the axis. Essentially, that's a fancy name for two of the bones in the most top part of the neck. It's kind of hard to see on this model, but if you kind of move this skull up, you have the odontoid, which is C2, and you also have the C1 bone. So the C1 bone and the C2 bone are the axis, the atlas and the axis, and they kind of rotate on each other. A lot of people ask me about range of motion in the neck after spinal fusions. Let me talk a little bit about range of motion in the neck after spinal fusions. The first thing to know is that you get 50% of this motion, the yes motion, from the skull and C1. You get 50% of this motion from C1, C2. When we're doing spine surgery, like neck fusions, 1 or 2 level fusions, they're usually C4-5, C5-6. So that's far, far away from this skull occiput, and C1, that's far, far away from C1, C2. So you still have significant range of motion after a 1 or a 2 level fusion. A lot of the range of motion loss likely already happened because you're already bone on bone. So the range of motion loss is still very minimal because you get most of that range of motion from the C1, C2. So Raj, kind of going back to your question about your C1 or C2 being misaligned, how would a fusion affect that? Well, it kind of depends on the underlying condition you have at C1, C2, and then if you ended up actually needing a fusion at C1 or C2. From Susan Yerger, will I ever be able to not feel my fusion from L3 to S1? Maybe. It kind of depends on what you're talking about in terms of feeling the fusion. In terms of the rods and screws, in most patients, you have so much tissue over this area, you're never actually really going to be able to feel your screws. Now, that's not always true. You could have something called a non-union or the screws pulling out. That's a major issue. And then, of course, you can feel the top parts of the screws. In the thoracic spine, kind of where your rib cage is, you definitely can have some thinning of the skin, and you could feel your screws there. That's not great at all, but that's feasible. But in the lower lumbar spine, kind of this lower area, it would be pretty tough to feel the rods and screws. I appreciate all the likes coming through. That helps promote this. If everyone kind of really pound those likes, that really helps promote this to your peers that are maybe having the exact same issue all across America and legitimately all across the world. So really appreciate the likes coming through, the follows, the questions. Those are important. Don't send me gifts. I'd really appreciate the kind gesture, but save those gifts for kind of other people doing the stuff for a living. So don't send me gifts, save it for someone else. Just kind of as a way to reset the platform. Again, my background is I'm a spine surgeon in Dallas, Texas. This is the area I grew up in, the area I'm raised in, the area I'm going to stay in forever. So like, this is my community. These are my people. I did my training at Texas Tech, University of Miami, and the Rothman Institute in Philadelphia. Miami had a devastating but expected loss last night in football, and some devastating injuries also. I'm happy to maybe briefly touch on those. Let me get to a couple other questions from Wonder Woman. Do injections work? They do work, 100%. Here's how they work. Let me find a pen. So in general, there's two types of injections in the spine. In general, you have the facets, and if you get injections in the facets, that's better for low back pain, kind of pain that just sits there. If you get injections in the nerves, kind of off to the side, then those are called TFESIs, for transforaminal epidural steroid injections. Those are much better for the shooting down stuff into either shoulders or in the legs. So a lot of patients that I say I want you to get an injection, I want to try all the conservative stuff before we go to surgery, are like, oh, I've had 1 million injections before, they never help. Well, maybe not untrue. If you haven't had spine surgery yet, maybe they have been helping. But the thing I always argue is I use the injections, one, to get you better, but two, to really confirm the diagnosis. I don't want to be doing any surgery if you don't get better. That'd be really unfortunate, right? So I use the injections to prove that the spine surgery that you're indicated for would help. A couple other questions I see coming through are the following. I saw, so busy, they don't explain Jack. Okay, great. I thought someone was talking about a couple other things. Great, someone's asking what's ankylosing spondylitis. Well, in short, it's a kind of a genetic predisposition to having arthritis in all the joints in the spine. Not great, very painful. Another question I see is, do you operate on patients with factor 5? So that's factor 5 deficiency. So yes, there's actually a couple on either side of the clotting cascade, or either you're hypercoagulable, meaning you throw blood clots a lot stronger than someone else, or actually you bleed a lot easier than someone else. So you can have factor 5 Leiden disease. There's a lot of other conditions. Definitely operate on those patients. You're not looking for that patient population necessarily, but pretty much I need a note from your hematologist, cardiologist. We kind of go over what the surgery risk and benefits are. Same thing if you're a patient that's a Jehovah's Witness, that's a patient that does not accept blood products. And sometimes we need to tailor the surgery based on that. Is the surgery worth the slight risk of loss of life if it's a certain type of surgery? The overwhelming majority of surgeries I do have minimal, negligible blood loss risk, so it's not even something I'm worried about. But there are sometimes, like when you go through the belly, where it's never happened to me yet, but there could have some major catastrophic issue, and needing to give blood would want to be something that you talk about with the patient beforehand. Again, it's pretty darn rare, but it's just one of these conversations that you like to have, and you like to have the whole team and staff prepared for it. So I see Breezy's been asking, I apologize for not getting this earlier. Again, appreciate all the likes coming through. Two topics I want to talk about next. One is Kquina Syndrome, and the other is pars fractures and spondylolisthesis. Let me talk about Kquina first. A couple ways to think about this. So your spine is, you have your spinal cord, starts in the neck, goes to the rib cage, and then around T11 is when the Kquina, when the nerve roots start, and then it really becomes the Kquina. So in terms of Kquina Syndrome, it's Latin for a horse's mane or a horse's tail. I think a horse's tail. And you kind of see how that looks like if you really squint and imagine. That's the horse's tail. So the Kquina and getting Kquina Syndrome is the following. Kquina Syndrome is when you have a compression of the Kquina. That's either from a massive disc herniation, infection, or fracture, or a postoperative hematoma. This expansion, this rapid expansion, causes a disruption to all of these nerves coming down here. That could be the L5 nerve. Usually it's also the S1 nerve, S2 nerve, S3 nerve. That causes numbness and weakness in the genital area, rectum, and in severe cases could cause weakness in the lower extremities, kind of depending on what level that happened. So that's acute Kquina Syndrome. Chronic Kquina Syndrome is a little bit of a different argument, but from an acute, something that's developed rapidly over the span of hours or days, that's Kquina Syndrome, and that's what they are referring to. Did you talk about spinal stenosis? No, let's go back and talk about spinal stenosis one more time. Melissa, that's a great question. So spinal stenosis, a lumbar spine, this is the number one thing I treat. I treat this every single day non-surgically and at least 7 to 12 times a week surgically. Kquina Kquina Syndrome is a type of spinal stenosis. That's where if you're looking down this part of the spine, different things have squeezed all of the nerves here. I'm going to use this model, but same argument. There's the spine. Looking down the tunnel of the spine, where all the nerves go down. When there's a compression of all of those nerves, the thecal sac, that is spinal stenosis. Stenosis is just a fancy word for tightening of all the nerves, and there could be multiple conditions that cause it. You could have a pars fracture or instability where one bone is slipping forward off the other. You could have a disc herniation that's pushing back. You can have facet arthritis, these joints getting really thick. That's another form or cause of spinal stenosis. I see a lot of people asking about telemedicine visits. Well, look, I don't want this to be an ad for myself. If you direct message me, if you reach out to me on either Instagram or on TikTok, you can direct message me and I can send you an auto-generated template of how the telemedicines work. The number one mistake patients make is they don't have x-rays. They have their MRI and maybe the surgeon they already saw who gave them a really bad interaction did the x-rays and they don't want to go back to that office for the x-rays, but I got to have x-rays. X-rays showed the stability of the spine. Usually it's 4 views: front view, side view, bending forward, bending back. X-rays are key. But you can direct message me. I do telemedicine visits all day, almost every day. From Breezy, talking about Kquina Syndrome, lost my ability to walk. Well, I hate to hear that. I would love to know a little more. Is that after a surgery you had? Is that something that's just developed slowly? And then if you know you have it and you can't walk and you haven't had surgery, I'd love to know why haven't you addressed it if you know that's the reason. Another question I have is, what's your favorite condition to treat? So my favorite condition to treat is something called a pars fracture or spondylolisthesis in the back part of the spine. That's on this back part of the spine from hyperextension injuries. So hyperextension injuries, you create a crack in the pars. When it's on both sides, bilateral, you get a crack here, and that eventually could lead to instability where one bone is sliding forward on the other. That sliding forward of one bone on the other leads to a collapse of the disc space, and it starts to result in pinching, severe stenosis, pinching of these nerves down here. That's what causes the numbness and tingling running down the legs, running down the thighs, running down the butt, and that's irritating, painful, and it decreases your quality of life. The reason that a pars fracture is my favorite thing to treat is because it's a very straightforward diagnosis and it's a very straightforward non-operative recovery plan and surgical recovery plan. Usually it involves a fusion. That's very frequently with a cage that goes into the disc space to give you that height back, to give you that lordosis back, and then very, 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 very frequently screws, such as this one I have here, screws like a pedicle screw that go in through the back muscles, kind of split the muscle plane, and that locks that into place so it stops sliding there. So why is it my favorite condition to treat? Well, look, if I can get you better without surgery, that's goal number one. But if you need surgery, the reason that pars fractures and spondylolisthesis is my favorite condition to treat is because it's very black and white. It's very clear cut. Fractures need fusions. They do not need disc replacements. They could get laminectomies, but that's a little bit of a gray area in terms of what's best long term. But fractures get fusions. If you break your femur, if you break your both bone forearm, unless you're a kid, you get a fusion. You know, we call it healing. We call it plates, rods, and screws. Same thing in spine surgery. The reason I like it is because it's an extraordinarily reproducible surgery, extraordinarily reproducible outcomes. Go ahead and what is black and white? Black and white means there's no gray area. It means it's either a yes or a no. You're either pregnant or you're not pregnant. It's kind of one of the terms we say in medicine. It's either a yes or a no. There's not an in-between. And that's why it's my favorite condition to treat, because it's just a very well-documented thing to treat. Spinal stenosis, on the other hand, well, now it's getting a little tough. Diagnosing the spinal stenosis is not always straightforward. What's the best surgery for spinal stenosis? Well, that's why people hate spine surgeons. You might show a spine surgeon, a group of 10 spine surgeons, the same x-ray and MRI, and of those 10 surgeons, you might get 12 opinions. That's the problem with spine surgery. There's a lot of ways to do it, a lot of ways that people think maybe their way is better than the other, and a lot of times maybe the way I do something is better than the way that someone else would do the same way I would do it. So maybe we're each better at our own skill set. So the way I do a X-lift procedure, like going through the side, might be better than the way someone does their X lift, but they might do an A lift going through the belly better than me. It's all just a little bit of what's the surgeon most comfortable with, what's his staff most comfortable with, and then at the end of the day, the patient exam and then the anatomy of the patient. If they have something called a high riding crest, so here's your hips. If it's high riding, you might not want to go at 4-5. Your psoas muscle that goes into the side part of the spine here, if it's called Mickey Mouse ears, there's no one out there should know exactly what I'm talking about, but on the MRI, if your psoas is a high riding psoas, you might not want to go through the side. If they have certain stomach issues in the past, you might not want to go through the belly. So there's a whole litany of things that really determine which surgery is best for that patient. When someone says they've never heard about someone getting better from a fusion, well, heck, there's probably 6 different ways to even do a fusion. There's multiple level fusions. There's minimally invasive. There's robotic. There's just many ways to do certain conditions, and that's why I just tell patients that not all spine surgery is the same. A couple other questions, and then I do have to run. I really appreciate all the likes. If we can get up to 10,000 likes, that will make me pretty happy. Again, my background is I'm in Dallas, Texas. I'm a spine surgeon here, grew up here, born here, raised here, family's from here, wife's family's from here. So Dallas is home. I'm not going anywhere. I'm not gonna leave this city and leave my patients high and dry. I'm gonna born here and die here. So kind of Dallas is home base for me. In terms of my training, kind of trained all over. Went to the Harvard of Texas, also known as Texas Tech. Then I went to University of Miami for residency, and then I went to the Rothman Institute for my spine surgery training. Now I'm back here in Dallas with my family. I do telemedicine all the time. Just go ahead and direct message me, and I can go ahead and let you know. Any tips for stress and overthinking from Envy? That's a random thing to say, but I think making a bullet point list. I say write 5 things on that bullet point list and just start knocking them out. That's, you know, the whole process of getting into med school, going through med school, and going through residency is all about the stress and being overworked and making lists. And so even on my phone, I don't use it as much anymore now, thankfully, but on the notes, I have a little bullet points and I just check them off and go for them one thing at a time. The Healthplex area in Miami is a traffic nightmare. I agree. It's a lot of traffic there in Miami. A couple other questions, and then I gotta go. I see my mom is calling me, so it's always important to take those calls. What helps with 2 bulging discs in the spine? My 16-year-old suffers from pain. Usually time, anti-inflammatories, sometimes steroids. What kind of boots do you recommend for standing all day in concrete work? I don't know. I use air-out boots when I operate and all the time, so I'm not really sure. NTOS. Tell me what NTOS means. I'm not sure. Free Palestine. Okay, thank you for sharing that. How do you feel about robotic spine surgery? I love robotic spine surgery. I debatably did the first or second robotic spine surgery in Dallas County. The debate is that when I did it in, I forget the year, 2021 or 2022, someone else said that they actually did one back in 2008 or 2009. A little bit of a different argument, but I'm not going to go down that. So I was either the first or second, depending on a couple of things. Thoracic outlet syndrome. Thoracic outlet syndrome is not something that a spine surgeon usually deals with. That's compression from the clavicle and the first rib. Usually certain upper extremity doctors take care of that. What can I do for sciatic pain and numbness? From Shannon. So Shannon, I'd say get an MRI. See what's causing your issue. The first way to get you better is to diagnose the issue. So when patients say they have sciatica, the number one way to get the sciatica better is to diagnose the issue. That's with both x-rays, side views, front views, as well as an MRI. Once you can identify what's causing the sciatica, then you can treat the sciatica. That might be with physical therapy, that might be with steroids, that might be with oral medications, that might even be with chiropractic therapy. Once you can diagnose the sciatica, treat the sciatica, if it fails, then you can always try the surgical options. Those could be very minimally invasive, those could be endoscopic, those could be fusions. It's all about the patient anatomy, the clinical presentation, and the expectations, and also patient lifestyle. In terms of a couple other things here, what do you think about chiropractors? I support chiropractors in general. I like them for the lumbar spine, not the cervical spine. Spinal stenosis, I'm getting a lot of questions on that. I've actually talked a lot about spinal stenosis already. In general, that's when you look down the tunnel of the spine, and that's when these nerves here get pinched from different things. Do you use stealth navigation? Yeah, I use navigation all the time. I've actually started using more augmetics navigation. That's the augmented reality, putting on the headset. I'm a big fan of that, but it's not at every hospital I go to. But I use navigation almost for every screw these days. I think those are great. ASC scoliosis surgery, hamstrings too tight, dry needling. Man, there's a whole lot to digest there. I don't think you should do too many big surgeries in an ASC, but it's all about what your ASC can handle and surgeon skill set. Do you believe in braces? Yep, I like braces. I order them for many of my patients. They definitely help. What's the recovery timeline for a TLIF? Kind of depends on how many levels. If they're doing it open versus MIS, I would say at the minimum 6 weeks, maybe 3 months. It kind of depends on how your surgeon's doing it. All right, everybody. Well, look, I really appreciate it. We got a pretty big follower count here, so I always hate to run, but I got to do some other things on this Sunday. Again, you can direct message me on Instagram or TikTok, and I can send you an auto template of how you can reach out for telemeds. The biggest mistake patients have is they don't have their x-rays. They have an MRI because everyone has that disc, but you need to get your x-rays. So go ahead and get your x-rays from your other doctor. They should be able to give you a CD of that. And I'm happy to talk about things. I can't give any medical advice online, of course, but look, there's a lot of bad actors out there, bad stories out there, and I'd love to kind of try to right the ship and help patients get better. There's no reason you should live in pain if there's an identifiable thing. The thing that patients get better from most reliably is shooting down butt pain, shooting down leg pain, numbness, and tingling. That's very, very reliably a pinched nerve. I use injections to diagnose that. If they get better with injections, but then the pain comes back, then surgery definitely could be a good option for you to recreate what's happening from that pinched nerve, is to take off that pressure. So that's what I focus on. All right, everyone. Well, look, I appreciate all the likes here. Appreciate all the many follows we got, but I got to get back to my regular life that's not this, although it does consume a lot of my life being a spine surgeon. Don't send me gifts. Send those other people trying to make money on the social media platforms, and I really appreciate it.